My name is Steven Milligan. I am a family physician from Pueblo, Colorado. I practiced full-range family practice in Pueblo for 27 years. For the last 4 years, I have been involved in the creation of Colorado Health Neighborhoods. My initial role in Colorado Health Neighborhoods was the chairman of the board at the point in time where we were developing the network. Within the last 12 to 18 months, I have taken on a new role where I am now the ACO Medical Director for Colorado Health Neighborhoods. In addition to that, I have also managed a Medicare Shared Savings program and am now part of a new startup that is called Fullwell that is working on taking risk within the state of Colorado with different populations of patients.
In general, what is an integrated delivery network and how does it fit into the changing landscape of healthcare?
The healthcare landscape is changing since the passage of the Affordable Care Act. The Affordable Care Act was looking to change the way we provide healthcare because the previous system, or the system before it was instituted, was not viable long-term. The cost of healthcare was going up faster than the rate of inflation. The Affordable Care Act wanted to bring a combination of quality and affordability by regulating what doctors do and how they get paid. An integrated delivery network helps provide that structure that allows us physicians to work with hospitals, skilled nursing facilities, specialists across the network to be able to achieve what we call the triple aim. The triple aim is some way of decreasing the total cost of care, providing increased quality, and improving patient satisfaction with their care. An integrated delivery network works together, primary care, specialty care, hospital care, to provide the triple aim.
The terminology can be a little bit confusing. Can you explain the relationship between an integrated delivery network, an integrated delivery system, and an accountable care organization?
So an integrated delivery network and integrated delivery system are probably just technical differences. What I mean by that is they are still working the same way, in that you have multiple different groups of people working together, PCPs, specialists, and hospitals. The difference is some people refer to it as a system of care, some people refer to it as a network. They're essentially the same thing. An ACO, which is an accountable care organization, is a relationship between a payer, for the most part, like Anthem Blue Cross Blue Shield or Aetna Healthcare, and a group of providers or an integrated delivery network to try and achieve the triple aim by providing better quality care at a lower cost.
One more term, can you explain value-based care?
It's best to explain value-based care in the where it's different from volume-based care. When I was practicing in Pueblo, I got paid by how much I did. The more patients I saw, the more I got paid. The more procedures I did, the more I got paid. That doesn't necessarily lend itself to increasing the quality of care to the patient, and in the long run is not something that is viable. Value-based care changes the payment mechanism to some degree to physicians. Now I get paid for what I do and how well I do it. So it's not as much about how much I do, but is how well I do it. That means I'm making sure that all my patients have their quality pieces taken care of, whether that's getting a mammogram or colorectal cancer screening, and I'm doing it in the most cost-effective manner, and I'm improving their satisfaction with the care that they receive.
With all that in mind, can you explain briefly how Centura Health Neighborhoods is responding to changes that you've described?
Colorado Health Neighborhoods is an integrated delivery network that has ACO arrangements with 4 payer partners across Colorado. We work with the payers to help decrease the total cost of care and improve the quality of care. If we are able to do both of those things, then we are able to take what we call spend out of the system. What that means is we're spending less for the same level of care. That creates essentially a savings. Each of these ACO arrangements will work with us and share that savings. They will split it with us in a specific ratio where the healthcare group keeps a certain amount of money and Colorado Health Neighborhoods keeps part of that money. What Colorado Health Neighborhoods does is then shares that with the providers so that they're getting paid for the extra work that they're doing.
How does this model of organizing health services delivery improve the patient experience?
So that is a very interesting and difficult question sometimes to answer. Our goal is we would rank or rate providers based on their provider or their patient satisfaction. What we do with that information is then bring it to the provider to say, your patients are perceiving their care in this way, and we'll bring a provider resource like performance improvement to the practices to say, you know, they say that your exam rooms aren't clean, or they say that they have a 2-hour wait in your waiting room. Here are some things that you can do to help improve the perception of your care to your patients. A lot of this is just educating providers on how they're being experienced by their patients.
Say a little more about how your organization then impacts the experience of the providers and the insurers.
So provider satisfaction is actually what we would call the fourth leg of that triple aim stool or a quadruple aim. If you don't have satisfied providers, the system isn't going to work. Right now, providers feel that they are overworked and underpaid, specifically primary care physicians. I'm actually walking into their offices and saying, you actually are going to have to do more reporting quality measures, reporting patient satisfaction measures to us. What our goal is to improve their satisfaction by paying them for those things. In the past, it wasn't paid for. So what we do now is we provide them with a what we call a PMPM, which is per member per month payment that helps offset some of these costs. Whether they have to bring on a new person to do some of this or not, they get a dollar amount for every patient that is in one of their ACOs. In addition, they get to participate in the shared savings on essentially the back end of this arrangement. Some of those shared savings checks to our very busy primary care doctors could be $25,000. So it's a significant amount of money to help offset some of the cost. Our goal as we go further along is to get off what we would call the treadmill that a lot of primary care docs are on. What that means is I got to see 35 people a day in order to make ends meet in my practice. If I'm paying you a PMPM up front and I'm sharing with savings on the backside, maybe you don't need to see 30, 35 patients. Maybe you can get by on 20 to 25 patients, and our goal would be to get you home for dinner every night.
In this course, we've spent quite a bit of time examining some of the barriers to increased access, lower cost, and higher quality or better outcomes across the entire range of healthcare settings. Let's take those factors one at a time. First, how does this model improve access to healthcare services for the consumer?
For the consumer, access to healthcare, specifically primary care, is extremely important and can be extremely frustrating. A lot of our providers are extremely busy. We look at 2 or 3 different measures to say, are you providing adequate access? We do something we call a secret shopper. And what that means is somebody who doesn't say they're part of CHN calls the practice and says, I'm a new patient, I have CHN as my provider, and I want to get an appointment. When is your next available appointment? And we track that and then provide that as feedback to the offices. The second thing we look at is sometimes patients can't get into their primary care doctor, so they seek alternative areas of care, the most common being emergency department. We look at rates of emergency department per 1,000 visits, and we then know what the norm is for our network and we look at the providers who are above that norm. We provide them with essentially blinded information where they know where they stand, but they don't know who else is in that system, but they can see how they compare. And that's a very powerful motivator. What we do with that information is then we reach out with our performance improvement team to say, how can we help you? Here are some best practices across our system that help improve access. Is that a mid-level provider or an advanced practice provider who just sees nothing but walk-ins during the day? Or she has 10 walk-in appointments in her whole day, so that allows patients who call in for an urgent visit to be seen at that time. The other thing we do is we understand that practices get busy. We also try to say, let's get you to the right level of care at the right time, at the right cost. And what we do is we provide them with information on the closest emergency room and what that cost would be, the closest urgent care and what that cost would be. We also deal with retail health and what is the closest retail health point and how much would that cost. And we have other things that we can do, which is like telehealth, which would be something like MD Live, et cetera, that allows the patient to get access if they can't get into their doctor's office at a more cost-effective point.
So that leads to the next question. Can you provide a couple of examples, other than the wonderful one you just provided, of how this model reduces costs?
So in addition, we know that the highest cost is what we would call inpatient care or care provided in the hospital. We have a team of care coordinators. They are what we call ambulatory care coordinators. We have about 14 of them spaced out throughout our whole network. What we do is we then risk stratify our patients into groups who are high cost, high risk individuals. These are people who have significant risk factors for being admitted to the hospitals. We then identify those people and reach out to those people to say, what can we do to help manage you in your home environment, which is where the patient wants to be in the first place, rather than having you go to the hospital. And then we partner with the physician through care plans, action plans, standing order sets that allow the physician to utilize the care coordinator to manage these people in the hospitals. In addition to those high-risk, high-cost individuals, we also can identify in real time patients who are frequent utilizers of the emergency room or are frequently admitted to the hospital. We then can connect with the patient and say, what is it that's making you go to the emergency room? Interestingly, a lot of it is social issues. A lot of it is, I can't get down the stairs. I need somebody to help me get down the stairs. And something as simple as moving them to a first level apartment solves their utilization problem. So we do social work. We have actually 1 or 2 social workers that also do this, that reach out and what is the services, what can we provide the patient to allow them to not have to utilize the services. And in addition, working with the doctors to help us understand that relationship a little bit better.
How will the model improve health quality and health outcomes?
All of our payers provide us with a set of quality measures. In the past, that has been done by the payers and it was just given to the doctor saying, you have to meet these specific quality measures. But they never told them what exactly it meant to meet that quality measure. And we look at things like numerators and denominators, and what does that mean? What is an exclusion? What isn't an exclusion? They're very complicated. What we've done is we've tried to standardize the quality measures and how doctors address the quality measures. We have a website that allows doctors to go in and get what we call evidence-based guidelines. And what that guideline does is it says, for this specific quality measure, this is, based on the evidence that we have, the best way of treating that. In addition to that, we then have a toolkit that we roll out with them, and it says, this is the measure. This is the definition of the measure. This is what is part of that measure, what you need to do, what would exclude somebody from that measure, and what the goal is. What's that percentage that you need to get to meet that quality measure? Colorado Health Neighborhoods defines the benchmark, and if a physician achieves the Colorado Health Neighborhoods benchmark, they meet all of their payer benchmarks. So if they do what we ask them to do, they should be able to meet them all. We then outreach to the patients with our performance improvement team to say, did you know they're there? Did you have access to it? The third thing that we do is we do something called a community portal. A lot of times, providers don't know who is driving that gap in their care. The community portal takes payer data from all of our payer partners, puts it in one place, and allows them to pull something we call a pursuit list. That pursuit list basically identifies the individuals who still need a specific quality measure done, whether that's a mammogram or colorectal cancer screening, and it provides them in one place access to that list so they can either work the list as a weekly project. I'm going to take this group of patients, or when the doc comes in to visit with the patient, he has what that patient needs right in front of him. So his nurse or MA can actually have done it before he actually walks into the room.
So how will you know it's working? What are the measures that you're really paying close attention to?
The biggest measure of success is whether or not we can generate shared savings from our providers or from our payers. What that means is we've been able to lower the total cost of care because there would be monies to be shared. Also, how much of that shared savings we get looks at how well we do on the quality measures. The problem over time, though, is as we are successful, the payers then lower the benchmark, which means we have to do even more to try to lower the total cost of care, whether that's doing something with people going out of the network or people going to a high-cost facility to get care, et cetera. What we're able to judge is we can actually measure over time how we're performing on the quality measures over a contract year or a performance year. And we also can look at how are we doing on utilization measures, including ED visits per thousand, inpatient admits per thousand, et cetera. And the last piece is, which is the more difficult piece, is how are our patients feeling about the care that they're receiving?
What are the barriers you face in implementing this basic structure, and what changes would you like to see in the evolving healthcare system that would address those barriers?
The biggest barrier right now is acceptance of the model, because volume-based care, getting paid for doing more procedures, is still out there. And for the majority of doctors, primary care specifically, out there, they're still getting paid on a volume-based basis. So that means that that's where they make the majority of their money, is doing volume-based care. The value-based piece is smaller, it is getting larger, but it's still not half of their business. So the barrier is that the docs still feel like I need to see more patients to generate my income, and the focus isn't as much on getting the quality measures done and decreasing utilization, which would drive the shared savings. So that's the biggest barrier. I think what the current administration is doing about driving value-based care is extremely important. If we can get more value-based care in the state of Colorado, it will then say to providers, wow, I really need to be focused on this, and it will drive them to doing value-based care rather than volume-based care. In my opinion, value-based care provides better care for our patients than volume-based care does.
This program is preparing healthcare managers. What are the knowledge and skill sets healthcare managers need to manage in this area of the healthcare system?
They need to be familiar with the newer payment models, the ACO agreements that are out there. They probably also need to be familiar with risk-based arrangements. Depending on where they end up, they may be in an environment where a significant proportion of their patients are in risk-based contracts. That would be a place like California or more onto the East Coast. They need to be familiar with what's the difference between risk-based contracts, ACO-based contracts, and just general fee-for-service contracts. They also need to know what are doctors being measured on? How do you help doctors perform better? In the past, it was the old we have the carrot and the stick, and the carrot was really small, but the stick was really big. And we're going to beat doctors up saying you need to do this, but we're not going to provide you with help. Docs are wanting to do the right thing. They want to take the best care of their patient. How can we help you, doctor, take better care of that patient? I think if they have that understanding, that mindset of partnering with the docs, providing them with tools that they can use, and not making their days longer, I think they'll get buy-in, and I think they'll be successful.
Are there career opportunities in this area that students should be considering?
Absolutely. This is a increasing area of healthcare right now. This is an area, this is the fastest growing area within healthcare, that the switch from volume to value. This is where the dollars will be spent into the future, and they can have a job, a career on either the payer side, so working with the Anthems and the Aetnas of the world, or in an integrated delivery network. There's probably even opportunity in large groups where they want somebody like this to help manage this. So there's multiple opportunities, and my gut feeling is they're going to get bigger faster.